Awesome. So I'm going to start with introducing Dan. I'm going to be reading here from a bio. So Dan Haimowitz, MD, is a certified medical director, a board certified internist in private and geriatrician who has been in private practice in Levittown, Pennsylvania for more than 36 years. He also serves as medical director of several area nursing homes and assisted living communities. He founded the Bucks County Long-Term Care Consortium and serves on the Bucks County Senior Task Force. He is also medical advisor for the Bucks County Area Agency on Aging, and he is a nationally recognized expert in long-term care and devoted advocate for older adults. He's participated in the White House conferences on aging and received the American Geriatric Society Physician of the Year Award in 2001. He received the William Dodd Founders Award for Distinguished Service from the American Medical Directors Association in 2009. He has served on AMDA, the Society for Post-Acute and Long-Term Care Medicine, in many key roles over the years, including as member of the board and on the Public Policy Committee. So with that, and I would like to say that I've known Dan for a long time. We both met each other when I worked for AMDA, the Society for Post-Acute and Long-Term Care Medicine. And he's a very committed physician, I can say, and incredibly passionate. And I'm very happy to have him here today. So welcome.
Nice, Meg. Thank you. I guess to summarize, so I do a little bit of this and that. I guess that's the upshot, right? It's always hard to introduce oneself. And I live outside of Philadelphia. So, we're a little sad, I guess, today, but that's how it goes. Now, I intend this to be, not that I'm that huge a sports fan. I want this to be informal. So first things is that you can put yourselves on camera. I'm really easy about this. If you're eating or, your hair doesn't look good, I've been there. So, feel free. You have me for the next, what time is it? The next 55 minutes officially, but I'll talk to you as long as you like. All right. I'd like to try to I'll listen to you and then I'll reply is, I guess, the deal. So whatever you want to talk about is fine. If you have questions and you want to interrupt in the midst of this, that's okay. If you want to wait till afterwards, Meg, our plan is basically try to do half an hour or less, right? And then discuss. So we'll see how it goes.
I have a question. I just put it on the slideshow because I'm doing the slideshow, folks. Did it look funny to you, or did it look like it was correct? Because it looked funny in my end. So I'm here. Do you see can you tell me what you see? Does it look okay to you?
Or others?
I'm sorry?
You want me to answer that or others?
Yes. No, well, you can answer that.
Well, you have but before you were looking at the slides with the slides on the side, this is a little better. It says slide 1 of 18. So this, I think, looks okay. Everybody okay with this? Although it has all the slides in the bottom. This isn't the slide. Yeah, that's better.
Okay.
That's better.
Sorry,
Yeah.
I fixed it. Yeah, I just figured out how to fix it.
It's the slideshow is what you wanted.
Thanks.
Right. Yeah. Okay. So this is what we're going to be talking about. Health and wellness, not just in the nursing home, but across the continuum, the spectrum of long-term care services. Next slide, please, Meg. So, what are we talking about, health and wellness? Well, obviously, when you think of nursing homes, particularly, skilled or post-acute, that's basically all about health. But I think that the bigger question, and what I wanted to get into a conversation today about, is how do you integrate medical care so that it's not a bad term, but how do you use it and make things better for people and residents, both in assisted living, in independent living, in the community, and where there are opportunities. And I think that might be a lot of the discussion today from your point of view, and I'll give you my perspective. Next slide. So there are a bunch of changes going on in long-term care. Now, I think this is both locally and nationally. For me, what I see happening in nursing homes is a big increase in private equity and real estate entities taking over nursing homes. So more of a for-profit. I mean, there's always been for-profits, but these days, I think with the combination of how things have been with COVID and finances, what I've seen is a really big takeover of very aggressive for-profit entities, which, if I'm going to be honest, and I'm always honest, is I'm not sure is the best thing for health and wellness of residents. But if you care to discuss, I'm happy to. I think there's a lot more no, back.
Sorry.
Thank you. That's okay. You're ahead of your time. The assisted living is something that's always particularly interested me. And for those of you who don't know AMDA, that's how AMDA works. Like, I think in the late 1990s, AMDA said, oh, we want a topic for a meeting. And I'm like, well, I'm interested in assisted living. So they made me the chairperson of their assisted living committee. That's just, how it works there. But there really are a lot of changes now in assisted living. It used to be that the whole idea of health was kind of pushed aside. We'll talk about this more at length, and there's some initiatives that are going on in assisted living, which I think will be interesting and helpful. Independent living we'll talk about, not quite as much as assisted living, but I'm happy to delve into it. I think that, again, COVID has really changed things, and it changed my perspective a bit on independent living. Now, I'm the medical director of an organization that has been a couple of CCRCs. And I think that obviously, nursing home, assisted living, and IL are part of that. But I think it gives an interesting example of how you can incorporate things from one level of care and use it optimally with some tweaking into a different level of care. I think it also goes without saying that there's a lot more older people, they have a lot more health needs, and the forces that are at play are trying to take some of these, and how do you move that into home and community-based services, which I have some experience with. Now, finally, the next slide. So let's go over some general geriatric principles. When you're talking about medication use in the elderly, one of the adages in geriatrics is start low and go slow. But I think that actually applies to the elderly in general. You don't, when people ask me, like, what kind of medication dosage do I use? They go, oh, you use half the dose, for starters. Like, no, I'd use a quarter the dose if I'm able to. It just depends, how tiny you can cut the pill up. But it's more of a conservative approach, which to me, begs the question of how do you do the geriatric threading the needle? I mean, I talk to families about this all the time. You don't want to discriminate against somebody just because they're older, because that is ageism, right? Not doing for somebody solely because they're older. And if you want later on, if you want me to tell a joke, I'm happy to. But the opposite side of that is, are you being too aggressive? You don't want to do something to somebody that they don't want, but on the other hand, you don't want to not do something to somebody that they would want. So when you're talking about integrating, health and wellness, it varies. One of the interesting things that I'm assuming about geriatrics is the increase in heterogeneity. As you get an older population, you see more differences between people. So the population itself has more differences. Something I say to patients all the time, particularly I have a very, very small office practice. I mean, very small, like 30 patients, outpatients, small. But when I sit down with somebody in my office, I talk about preventive medicine, because, preventive medicine is all the rage in younger people, right? So I say, well, it's the same thing. Preventive care is just as important in the elderly as it is in younger people, but it's a different sort of preventive medicine. I'll say things like, you should make sure you have eye examinations, and you should see the dentist, and you should get an audiology evaluation every 5 years. Diet's important. Regular physician visits are important. Exercise is so important in the elderly. And I say some of these things because when we talk about how you integrate health and wellness across the spectrum, you just can't think, well, just because they're older doesn't mean we can't do these things. It's a little different, exercise, for example. It's just different. Like, I do not recommend, and a good thing about a talk is if you get one important thing out of it that you can take home, right? So what I say is, in my population, I do not recommend things like tackle football. I think football is a really bad sport for 80 and 90-year-olds, because they'll like get hurt, So you want exercise, but you want things like, low impact, running, you want things like swimming is really good. Just walking is really, really important. There's so many benefits to exercise. And if you're going to talk about how do you put in a health and wellness in any kind of setting, I think the emphasizing exercise is one of the key things you can do. And these are just some of the examples that, I use in my practice is, you want to look at things like screenings, and the younger and the healthier population, the more opportunities there are, which is why if you're looking at putting this all together, you could argue that it's more important in IL than it is in AL, right? Because by the time you get to the nursing home, generally, you have a sicker, less able population. Now, when I'm talking about a common disease states mentality, it's sort of like I'm referring to the aggressiveness, which is, and I tell this to people all the time, I think when you get really old, older, 80, 90, and it's not just age, but it's how many other illnesses, the comorbidities somebody has and frailty. For example, high blood pressure. I believe that it's safer to have a slightly higher blood pressure than a slightly too low a blood pressure. Low blood pressure is, I think, dangerous in the elderly. Diabetes is a good example. I think running slightly higher blood sugars is safer than a low blood sugar. Hypoglycemia can be deadly. Slightly higher blood sugars, slightly higher hemoglobin A1Cs. A couple of my sisters live on the West Coast, so they are Kaiser Permanente, and they're like, apparently the key hemoglobin A1C there was like 6.3. So if you're like 6.4, an alarm goes off, and you're ding, 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 and you have to go see the endocrinologist. You want to relate your hemoglobin A1C related to what somebody's quality of life and goals of life are. So hemoglobin A1C of 7, 7.5, 8, it depends on how old and what underlying diseases you have. I took care of a patient in a nursing home once. She was in her 90s. She was very demented. Her hemoglobin A1C was like 14. It's like, well, so what? If she enjoys eating sweet food, let her eat sweet food. That's what her quality of life is about. And it's just trying to have this flexibility if you're talking about including health and wellness programs, because certainly with the elderly, one size does not fit all. You got to put on a different hat. You have to have a different mindset with geriatrics. What I always talk about is rather than one, and by the way, for common disease states, the same sort of thing goes with the cholesterol. A slightly higher cholesterol is, I think, okay. A low cholesterol is actually a very poor prognostic sign that somebody's going to die soon. But, you still see in this world, very old, very demented patients who are still on statins for their cholesterol, which doesn't make a lot of sense. I've said for a long time that if you're, rather than looking at common topics, hypertension, diabetes, high cholesterol, I think the key thing when you're dealing with the elderly or in general is communication and education. Those are the two main pillars of what I think everything is built upon. And it's the same sort of thing if you're talking about integrating health and wellness into whatever setting you are. If you think about, how do I communicate better with the residents, with the people? How do I communicate better with their families is so key. And it's hand in hand with education. I was once at a retirement community giving a talk, which I'll talk about. And I was mentioned about that, high blood pressure is not necessarily that bad. There's this one study like in Canada where they're talking about if you have somebody who's very old, who's very frail, has really bad underlying diseases, and I will say like something like dementia. I look at dementia as if it's a terminal illness, which is, again, a different mindset of looking at things. And, this Canadian study says if you get to a certain point, it doesn't matter what your blood pressure is, 180, 190, doesn't matter. So one of the audience members was like, look at me, her mouth dropped open. And she's like, I've never heard anything like that before. Of course you haven't, because I think the big problem is that there aren't enough geriatricians. There just aren't enough of us. And I think there's not enough geriatricians, and there's even not enough of those of us who do long-term care. So next slide, please. These are all the challenges, these, right? Staffing and workforce has really come to the fore. We're dealing with regulations. I think particularly with COVID is the stress and burnout. COVID has really shown a light on a lot of the problems. And certainly everything is, I thought it was actually supposed to be an electronic world, and there wasn't supposed to be all this paperwork. I should do a panoramic of my desk, which has nothing but papers, but all these issues. Next slide, please.
Sorry.
So that's okay. And if you want to talk about any of this stuff, feel free, that's what we're here for. But I think where the opportunities are is how can you take a best practice, what you're comfortable with, what and take it from one setting and adjust it to another. Next slide. Take assisted living, for example, which I told you I'm very interested in. One of the things that's always bugged me is, AL is state specific. So you have 50 different laboratories, sort of, is the concept, each doing their own thing. Well, maybe that's good, maybe it isn't. Because if you don't have somebody saying, this is a best practice that works, how will you know what's good? But it develops, how it turns out is that in each state, they have different names for assisted living. There's like 40 plus names for assisted living. I never really understood why that was the way it is, but it is. If you look at the number of residents in assisted living, there are more residents in assisted living now than there are in nursing homes. The number of assisted residents is going up, nursing homes is going down. But, in a lot of ways, and in some settings, the assisted living residents look a lot like the nursing home residents, and they have increased frailty, increased disease states, increasing comorbidities. So, to me, that screams out, there's an opportunity to integrate health and wellness into assisted living. Something that's always bugged me is, this has been for decades, the whole social versus medical model, where, assisted living communities would say, well, why should we do anything medical? We're a social model. Well, I just think that's burying your head in the sand. People didn't go to assisted living in order to socialize. They go there because they have medical problems and they can't stay at home. That's just how it is. It's the reality. Next slide, please. So here are some of the opportunities which we can, again, discuss at greater length. I wasn't sure whether the term, it used to be the term medication reduction. Then we used the term de-prescribing. Now the current PC term is medication optimization, which is actually a good term. Not just taking away medicines that people don't need, but starting medicines that they do. I mentioned antipsychotics. I'm sure you're all aware that antipsychotics, there's federal regulations about mandatory gradual dose reductions in the nursing home, but there aren't any in assisted living. So what a great opportunity is to look at assisted living and say, can we cut down antipsychotics or really any psychoactive medications before they need a higher level of care? And even if they didn't, it's still good for people. Antibiotic stewardship, and which a lot of time relates to, it's the misdiagnosis and overtreatment of urinary tract infections. But just besides that, there's all kinds of things where you could educate people about antibiotic stewardship in assisted living. Talked about preventive medicine, having interactions with physicians and nurse practitioners and PAs in AL. I mentioned communication. There's some initiatives going on about using, there's no mandated use of, well, there isn't nursing homes either, but it's underdeveloped for electronic health records in assisted living compared to nursing homes. Pharmacists are required in nursing home, not in assisted living. That's an opportunity. I wrote my textbook there because I should have brought this along as an AV guide. When people say I wrote the book on assisted living, I actually wrote the chapter on assisted living in a pocket guide to long-term care. My advice to you, here's my second pearl, is if you have the opportunity, don't write a textbook chapter. Okay, it's miserable, it's terrible. They came up to me, and Meg knows that I'm always, people ask me to do something and I say, sure, why not? So they go, hey, write a chapter. It's easy. It's like a college thesis. It's terrible. So don't do that if somebody tries to sucker you into it. Okay, I'm just in my experience. There's use of also working with pharma. Now, I'm not saying I totally support the pharmaceutical industry, but I don't demonize them either. So I think if you do it right, there's opportunities in other levels of care. And finally, medical direction. Next slide, please. I am not here to browbeat you all into saying that what you got to do is you got to have medical directors in other levels of care. I could if you wanted me to. I mean, I support the concept. I think it's a good idea, but I'm not saying it has to be mandatory, right? I just want to talk a little bit about, I think there are advantages of it. For example, I was a medical director in a couple places, a couple of assisted living communities during COVID, and I did a ton of stuff. One place had these coronavirus response teams, the CRT, where we were meeting in early 2020 for 8 hours a week, and actually took some of those lessons and took it to a different assisted living who weren't doing any of this stuff. There were videos, there was interactions with the hospital, wrote articles, talked to families, did webinars. There's all kinds of different things that I think if we're encouraging medical direction in other levels of geriatric care, not just nursing homes, I think it's a good idea for everybody. Next slide, please. And I can elaborate on any of these things. So the advantages and disadvantages, to me, where I think is the biggest advantage of a medical director in assisted living, and I don't know why this doesn't get enough press, is it's so huge for liability protection. Like I've been to places where I have not been the medical director, and they say, oh, we can't get a hold of Dr. Smith. Somebody's lab work is all wacky, and we don't know whether to give their medicine or not. And they would turn to me and I'd go, what do you want me to do? I don't have any authority to do that. So the nurse would say, well, maybe we'll just hold their medicines by accident, that sort of thing. It's the amount of money that you pay for the protection from liability, I think is so enormous. That's the key advantage. And I think I don't agree with this, but I think having a physician has a different cachet, to people. You know what I mean? It's like saying, for some reason, oh, I'm a doctor carries weight. I mean, I think everybody's personally equal, but people look at that differently. I think it lends a certain something. And it doesn't have to be, by the way, medical direction in assisted living. It could be things like, physician advisor, whatever term you want to use. The real disadvantage, I think people have always complained about the cost. Like, when I was involved in this national project back in 2005, they're saying, oh, AMDA is advocating for medical director in assisted living just because they want to get paid. I don't agree with that. I think I know for a fact there's some physicians, because I'm one, I don't be a medical director of assisted living for the money, and I don't want a whole lot of money. I want to have the opportunity to help care, but there is some financial impact to that. And as I said before, there's hard to find physicians who are really interested in this. Next slide, please. It's interesting in the AL world. There's this initiative that AMDA has started that's called Be Well in AL. I don't know what it's going to incorporate yet. It's in the very early stages. Cheryl Zimmerman at the University of North Carolina is spearheading this, and she has support through AMDA, which is also interesting because the SEAL, the Center for Excellent Assisted Living, I didn't know this, has apparently been taken over by UNC. So it's no longer the SEAL, it's the SEAL at UNC, and Cheryl Zimmerman is going to be the executive director. I don't know what it's gonna mean, but I hope it's gonna be good. I personally facilitate this group of it's multidisciplinaries. There are not a whole lot of us who show up through the AMDA California chapter. And if any of you are interested to listen to me riff for an hour, I'm happy to give you the website for that. Alfred Johnson, who's involved with NARA in Wisconsin, is actually developing best practices to see if we can take it to state regulators and have some kind of consistency. So there's interesting stuff. Yes, Meg, did you want to say something, or are you just flexing your
What
hands?
is NARA? No, what is NARA?
That's the National Association of Regulatory Agencies.
Oh, okay. Okay. Thanks.
Next slide, please. So let's talk about IL a minute. Obviously, there are no regulations. There's no national group for independent living, right? But like what happened during COVID was, you were just getting all this information just fly. It was like, drinking through a fire hose, I think is really apt analogy. So, we knew what we were being told to do in nursing homes. We sort of knew what we were being told to do at assisted living, but we had no idea what the regulations were in independent living. So, again, tried to take what worked in higher levels of care and adapt it to to independent living. So for one like brief moment, I'm like, wow, I should talk to a bunch of the ILs who are in CCRCs, and we should get together, like form a group to work on this, because it's a natural, right? But then I came to my senses and I'm like, no, that's way too much work. I am not doing that. So should we have national regulations for assisted living? Oh my gosh.
Good question.
I'll hold off on that. I'm happy to elaborate on that. That's a great question. But I think if you're talking about integration of health and wellness, it works perfectly in IL. Next slide. Like what you say. Oh my gosh, here you go. That's amazing, Meg. We talk about QAPI, right? So, nursing homes are mandated to have QAPI. I see more and more AL, but in like the CCRCs, they're invited as part of the QAPI process. And, what is QAPI but a way of thinking? It's like making process and systems. And I kind of think of QAPI in my personal life too. My wife is not so happy about that. Like she freezes up when she hears the word root cause analysis, because to her, root cause analysis is like the worst thing ever. It's like an hour meeting. Nobody comes prepared. It's terrible. Maybe I shouldn't talk about that. We can talk more about my take on root cause analysis. My idea of root cause analysis is just, hey, just asking questions as to why something happened, and you can easily do that in IL. You have falls, right? That's a great instance of incorporating health and wellness to try to be proactive. I don't know if any of you work in IL, but what I wish they would do is, it seems like every month we have at least one person who set off the fire alarms because they had smoke from their toaster ovens. So, it's like we should look at it as some kind of QAPI indicator. But to me, it's like, is it a sign that somebody's having memory loss, that they're not safe at home? And I know that people don't want to move through levels of care because it's like the worst thing that could happen. But again, education and communication. People in IL take medicines, families want to hear things. I was telling Meg at one of the CCRCs where I was having that talk, we would bring in people. Like I would give talks, other consultants would give talks, cardiology, pulmonary, medical supply people. And we always had the talk. They always started at 7:35 p.m. You know why it started at 7:35 p.m.? Meg knows. I'll just tell you, because Jeopardy ended at 7:30. So they had to go to Jeopardy and then they would come down to the thing. Next slide.
I do have a question about this.
Yes.
This slide in particular, you said, is this assuming all of these things that you said would be opportunities in ILs? Is this assuming that there's a medical director overseeing? Because obviously there are no regulations. There's no medical profession. There's not generally a medical professional overseeing what's happening in an IL, right?
Right,
So,
correct. So,
yeah.
For the most part, I think medical directors are in IL when they're part of the CCRC. Now, the CCRC does not have to include IL as part of their QAPI meetings. Some do, some don't. I mean, QAPI meetings vary all over the map, So I think that, do you have to have, are you required to have the medical director in IL? No. Could you consider it? Yes. But there's not even any good, I wouldn't even know how much to reimburse, how much a medical director would want, because it's, it's the different setting. Certainly, I think, you wouldn't be paid as much. But a lot of this stuff, I think it's, look, you don't even need a medical director. I think you could talk to a physician who's interested in these sort of things and say, hey, now, obviously somebody, if you say, hey, look, we want to do a mini QAPI because we're not doing it, you'd want somebody with some experience probably in the nursing home with QAPI. But these other things, falls, medication optimization, preventive medicine, talking to families, you don't have to be a medical director to do those things.
Right.
Next slide. But that was an extremely good question, Meg. And this is kind of moving over to health and community-based services. I've been medical director of a PACE program, which is the epitome of all-inclusive services. Yes, Joanne. You're on mute. That is Joanne's hand, right? Isn't it, Meg? Looks like Joanne's hand.
I actually cannot see.
Sorry, I'm unmuted.
There you go. Yes, Joanne. Joanne?
Yes. Is it fair to say that, some of the stuff can be kind of low-hanging fruit and not real formal? In other words, bringing physicians or say bringing pharmacists in and say on Thursday, we're going to have a pharmacist in the common area and he'll be doing a brown bag review. So bring your medications and he can do a review. So can we do things like that are more informal programs, but can still address some of the, kinds of health issues? Should ILs be doing more of those kinds of things, or is that an opportunity that they should be taking advantage?
Well, I think both, right? I think it's certainly an opportunity. Yeah, I think it's certainly an opportunity. And I think that's what people want. Now, to some degree, I think you have to align incentives. So, do you think, is a pharmacy necessarily going to be coming in and doing a brown bag review? Mm-hmm. Maybe, it may be a way of marketing themselves. But I can tell you, at least where I am, there are many more independent pharmacists than I've seen this cycle. There used to be, when I was growing up, it was nothing but independent pharmacists. Then it was all the CVS's and Rite Aids and Walgreens of the world. Now I'm seeing more independent ones who are branching out. Like, for example, I have an independent pharmacy near me who's their main thing is giving medications to assisted living communities and PACE programs, right? So I think that if you can develop the relationship, it's a win-win, hopefully, for everybody. The pharmacy gets some recognition, the residents feel like they're being heard, better care is being given, and you could argue that if you're doing right with medication optimization, and there'll be a point I'm going to say in a second, it's good for the bottom line, because you're making people feel better, satisfaction is better, you're reducing falls, you're keeping people wherever they are, they're aging in place. So to me, there's nothing but advantages for it. And again, all this is, I think insurers and ACOs are seeing more of the, the spectrum of the long-term of geriatrics outside of an institutionalized setting. Next slide, please. So this is the overall arching themes with staffing. I don't think anybody really has an answer through staffing. There was something really interesting. I don't know if you've heard of Project Echo. Echo is something that started in New Mexico through GI, and some of the gastroenterologists felt that, the community doctors don't really, how do we get information? How do we communicate? So it was a all teach, all learn concept. So what had happened was during COVID, the federal government actually paid nursing homes. They developed all these people around the country, different people who could teach. They developed a common, modules, and they paid nursing homes, I think, like $6,000 if they attended 90% something of the sessions. So then they had a second part, which was open to everybody, including assisted living, but they didn't pay people anymore to come. So guess what happened? Not nearly as many people came, but it was really, really interesting stuff about listening to staff and validating them. And my personal opinion about staffing is that it's not like, oh, I'll move from one home to another because they'll pay me 5 cents more an hour. If staff feels heard and listened to in the atmosphere, I think that is a huge thing with, at the very least, keeping retention, maybe not recruiting. Talked about aging in place, which is important. And I do think if you want to talk about, advocacy, both for patients and, caregivers and legislative, I'm doing a lot of advocacy these days. Next slide. And all these initiatives, there's Moving Forward, which is a big nursing home. It generated out of Biden's State of the Union talk a year ago about these 7 different areas that nursing homes can improve. So it's a big initiative. They have like funding through IHI, and they have the 7 subcommittees, and they're going to work on this on a 2-year schedule. We'll see. You always wonder if any big government projects will really happen. I'm hopeful. What's way better is One Voice. I don't make do you want to tell them about One Voice in a word?
Sure. No, One Voice
qualified?
One Voice is sort of the slacker version of all these initiatives. We just get together and talk about, I'm part of One Voice, by the way. It's just a group of folks who have been working in the field for a long time, and we get together monthly to talk about how we can generate ideas about how we can improve long-term services and supports that we talk about across the spectrum, from nursing home, assisted living, every home and community based. We're an informal.
And it was going to be called Good People, but the name was taken, I think.
Right.
So AMDA does I just made that up. AMDA does the drive to de-prescribe. It just shows there's focus on de-prescribing. We talked about Be Well and AL. Advancing Excellence has been around for a long time. Is there really change? I'm not sure. Next slide. So here's just what I want to talk about, to maybe we can think of a lead discussion. I think it's certainly true that long-term care residents do have a bunch of medical needs, probably more than the community, but there are plenty of people in the community. So when you're talking about integrating health and wellness, I think they could benefit from that. Customers want medical care. I mean, one of my friends tells me this all the time. It's like, I just don't think, when assisted living says, well, we're a social model. Yeah, but why would a social model? They're not coming there for social stuff. They're coming there for medical problems. I think now, I don't want to, say baby boomers, but I think the phrase health and wellness resonates with people. So I think if you're saying, look, we're really looking at your, emotional and spiritual needs, I think health and wellness just dovetails right in there. And which I mentioned, the integration of health and wellness, I think can really affect the bottom line. It helps. Surveys are better. The community thinks better of the community or facility. People don't fall as much. They don't go to the hospital as much. They feel better, so on and so forth. I think that's it. Next slide. Is that it? I think that was it, Meg, right? Okay, so you enjoyed our little talk. The floor is yours. Do you want me to start with the regulations, national regulations in assisted living? Okay. Do any of you work in AL? If you do, the way to start a fight in assisted living is say, yes, I actually think I really strongly feel there should be regulation, national regulation in assisted living, because then everybody gets super angry and we just yell for a while. All right. But I'm not that kind of guy. I'm not. See, I try to be reasonable about this. I think it's interesting that there hasn't been national regulations on assisted living. This is back in 2005. This is when Meg and I worked together on the assisted living work group. There's a whole bunch of different providers. The government brought them together, and it was an unfunded mandate to say, fix assisted living. Because the issue is that you have nursing home-esque patients there, residents there, and there's no guidelines. And all you do is hear the occasional horrible stories of abuse and care. But we couldn't reach consensus, and short of the seal being founded, nothing really happened, right? And part of me, and I think part of reasonable people, wouldn't want national regulations on assisted living, because you don't really want to turn assisted living into nursing homes. Nursing homes are so way overregulated, right? So our phrase of the day is, how do you thread that needle? How do you do something that, it develops the win-win, or at least develops a good compromise? Good compromise is where both sides are completely satisfied, where you can ensure you're getting good care, but people still make a profit. And there's nothing wrong with making a profit, So I think if you had reasonable national regulations, it would be good. What I think right away, the first thing to do is, if you want to just put your toe into the pool of assisted living national regulations, is make the naming of it standardized. I mean, it's so easy. Instead of having 50 states have all these different names, just get everybody together, pick 4 different names for what the things are, and stop all this confusion, for heaven's sakes. But it's not going to happen, because it's way too reasonable, and we're talking about the federal government. Oh, wait a minute, you're taping this, Meg, right?
Yeah.
Oops. Oh,
So
well.
I have a question. A couple of questions. First, with regard to IL, what have you seen? What examples can you give us, if you've seen any? And maybe Joanne can also help, of really good health and wellness initiatives in IL. I'm just asking in particular to IL here.
Well, as I told you, well, I'm sorry, Joanne, ladies first.
No, I'll leave that to you.
I defer to you, Joanne.
Well, the only kinds of things I've heard is that the facility, communities are using more technology and offering more technology for self-monitoring, things like the Alexa and monitoring systems, the wearables, that kind of thing, to help keep people safer in their homes. Even the things like the toilets that that analyze waste when it goes in, and printing out a report that goes to the doctor. And also somebody told me that they're designing senior living communities, and some of them have office space in there for home and community-based services.
Right.
So those are the big things.
Like PACE. That sounds like PACE, doesn't it? Yeah.
Well, right. I mean, I think mine have been, like I said before, we used to have a series of lectures. And I think, communication is a really, really easy win-win, because you educate the residents, and you get either the consultant group, or who, the agency gets to market themselves. So I think, if you're realizing, that there's some bias in there, it depends on what the talk is. I think that's a really easy one. I think we used to do this a couple times in assisted living. I think it works at IL. All kinds of it's easy to do a screening. You can do a blood pressure screening. You can do an osteoporosis screening. I'm a little down on osteoporosis treatment in nursing homes, because to some degree I feel like it's too late. But training in IL, for osteoporosis, that's people who would benefit from it. I hope a lot of people do this, but things like Tai Chi and balance lessons, and to me, that's health and wellness. So I think there's all kinds of programs. You could have more family nights to discuss medical issues, because the medication optimization, I think, is a great example. Technology is another one. You used to be seeing this stuff in assisted living, where people do kinds of stuff with the bed scanning things and all kinds of, but now families can look at stuff with portals. You can have blood sugar monitoring from devices. You can do a lot of stuff now that you couldn't dreamed of years ago.
Right. So I have another question. And
one second, before you continue, Meg, I think this is one of the things that I think thinking about health and wellness is important. One of the things that's happening around me is you're getting the 55 plus communities, and I'm assuming this is a national trend, right? But I just don't think there's good thought process behind this, because they're being built for healthy rich 55-year-olds, right? Yeah. So what happens when they get sick? Is there safe places to walk? Do they have a covered path to the club room? The example that I always use is when my dad had moved to an assisted living when he couldn't stay at home anymore, and he couldn't brush his teeth. Now, why he couldn't brush his teeth was because his wheelchair hit against the bathroom. What's it called, Meg? The
Think the counter,
the vanity.
the vanity.
So they hadn't thought that people would be in wheelchairs. So he bumped it, and he couldn't reach to the sink. You know, so it's like, I don't think people think about healthy, but they don't think about what's going to happen when people get sick, when they age in place.
Yeah.
I think it's a society thing. Meg, go ahead. I'm sorry, I interrupted you.
Well, that made me think, so the 50, when you mentioned 55 plus community, age qualified communities, isn't that the same as AL? Don't those have to be built as IL? I mean, IL, I'm sorry. Or there aren't even really any regulations around it. And there must be some about building a 55 plus community, which to me seems like an IL anyway. Or
right. It's similar though, right? I mean, when I was thinking about the ILs here, I was thinking more of like, you know, in a bricks and mortar, all in one building. Do you know what I mean? And the 55 plus are more or less, you know, glorified townhouses, right?
yeah. Oh, so I hope I pronounced your name correctly. Waiketa? Or
Yes, it's close, Waikita. So
Waiketa, I'm sorry.
yeah, that 55 and plus is to avoid regulations, right? Because you won't have to follow regs because it's a community, right?
Right.
So you don't follow the same regulatory process as we would for other communities for seniors. So that's a way around
Right.
your state regulation. I mean, I hate to say it, but it's true. That's the way that's how you get around things.
Yeah, I agree.
So-
And you know, if you just look at conceptually though, I'm really not sure that that's the healthiest thing. You know, is the healthiest thing to have, you know, just all 55 plus year olds, or a combination of younger and older? You
Well,
know,
I mean, I'm very much for the younger, the intergener. Well, you're
I am
saying
too,
younger.
intergenerational.
I
Yeah,
like intergenerational.
so do I.
And Waikita, you said you wrote something about Tome Rivertown. Do you work at Tome Rivertown?
I went there this year. I went there earlier this year on a tour, and I think that they're just a fabulous example and model to how we should look at the PACE program, AL, assisted living, the greenhouse project, all that was in one. And they did have dedicated office space at Tome. It's considered Tome. It's a Rivertown. For PACE, and the way the building was designed and the entrance way for PACE to come in and out with the people who didn't live there, which is excellent. But it's all about collaboration. PACE is not fighting Tome River and the people that live there. They're all working together. And that's hard to find. And I think they're definitely a model for the nation.
And
I agree.
right, no, I would agree with that, but I think the problem is you look at the greenhouse project and Eden and stuff like that, and it's not like it's sweeping across the country, you know, taking over places. You know, is PACE great? Yeah, I think it's slowly but surely, you know, increasing, but obviously it's finances, it's collaboration.
Correct.
There's so many other things going on. I mean, you look at you talked about the building, right? So I work at one assisted living facility. I'll give you names if you want, where I think it was designed well. It's a square, you know, blue, green, you know, purple. It's really easy to figure out. I've gone to other, and it's a assisted living for memory impaired. I've gone to another one where I get lost walking in there.
Right.
And if I get lost walking in there, I have no idea how the residents with memory loss find their, you know what I mean? It's like some other things are going on behind the scenes, you know? So, okay.
So, I will say I've been to Tome Rivertown. It is beautiful. I love it. It is a great model. I was there as when I worked for the greenhouse project, as a matter of fact. So it is a greenhouse, but it's also PACE, and it is really a great model. I agree with you. Yeah. And I suppose, since we're talking about health and wellness, that, I mean, PACE is just very much, that's part of their, I guess that's very much part of their mission, right? I mean, isn't that what PACE is really about? Wouldn't you say, would you agree?
Well,
Dr.
The
Dan?
mission, yeah, I mean, I've been a PACE medical director. The mission of PACE is to keep people living at home. I mean, that's their mission, and whatever it takes to do that, in a nutshell. But it's hard, it's hard work, it's complicated, there's a lot of regs. It's just not easy work. My favorite story about PACE is there's this national renowned geriatric expert who tells me he was working at a PACE program, and he went home to his wife one day, and he says, "Oh man, I'm exhausted. I've been working at PACE and I've been there like all day from like 8 to 6. She goes, "Oh honey, that's terrible. How many patients did you see?" And he goes, 4. That's true. It's a true story. Because there's, you
But
just have
it's
to talk
probably a
to
good
everybody
thing.
and document. It's tough. I'm sorry, Meg.
That's probably a good thing for PACE, right? Because he's spending time with his patients and he's helping.
Well, but it's the patients and it's the other members of the team, and you have to get stuff authorized and you have to document. And, you're always fighting with people. You're fighting with the ER because there are many people they shouldn't. You're fighting with prescribers who are documenting the wrong stuff. It gets a little wearisome. But it's
Okay.
God's work on earth from somebody who's not particularly religious.
Another question. Let's see. Should or can IL communities recommend that residents be assessed for things like frailty on admission?
Well, I don't think you can force people to do things, right? I mean, I think threading the needle here is trying to be proactive, because it's the mindset too, is like, if you went to somebody who's living in IL and you're saying, hey, the message is, I'd like to find out if you have medical problems. I'd like to find out if you have memory loss. They would never agree to that, because to them, that just means, they're not going to accept them, or they're going to push them to go to, AL, or God forbid to them, the nursing home. So it's, you have to, I think, develop this atmosphere in IL, at least with health and wellness. We're doing everything in our power to identify stuff so that we keep you here, right? Because that happens at home, right? Where people don't take their meds wrong, fall, but don't tell anybody.
Yeah. I don't see any more questions in the chat. If anybody has any questions, you could raise your hand or take yourself off.
Yeah.
mute.
What's on your mind? What's on your minds? Don't make me call your names. Go ahead, area code 386.
I do. What, do we have a hand up? I didn't see one.
Well, it
Okay.
doesn't look like they're not on mute, or Wendy's not on mute. Maybe she wants to say something.
No, Wendy's on mute. That's probably the computer. I'm 386 also.
Shoot. Come on, anybody else? It's your big opportunity. You can ask whatever you listen. You can ask whatever you, except for Meg. You can ask what you want. Should I say my ask? You want to hear my ask what you want story?
No, I do have a question though. I really do have
I
something.
have a really good ask what you want story.
Okay.
It's really good. Well, but somebody has to ask me. Some of the people who are on mute have to ask me, say they want to hear it.
I would love to hear it. This is
Sheena, that's a very good, it's a really good story. So a very dear friend of mine decided to give this talk at the nursing home about ethics, right? So she gave an hour, a 55-minute hour talk on ethics, Socrates and Plato and beneficence and autonomy and all this stuff, right? So it's really, really good. What's the name of the woman who was in the car crash? All these things. So she finishes it up and she says, anybody have any questions? So a guy puts up his hand. She says, yes. And he goes, is it still the right time for me to get my flu shot? See, so you can ask what you want.
You should been a comedian.
Well, I'm a casual observer of the human condition. So you have a question, I believe.
No,
Meg?
it's just a comment. So all this, the talk about health and wellness in senior living, in IL and mostly probably, I guess it's happening in IL. But here's my question. To me, isn't that like encouraging health and wellness in IL is one thing, but then when you get to AL, having some kind of health and wellness program in AL, to me, it seems like a very obvious thing. Like, why don't AL providers I mean, I assume they already do, but do they really? I'm sure they do. That's what, their function is to, of course,
Well, remember that there's such a big difference in assisted living communities from, 4-6 bed mom and pops to like nursing home light, almost like nursing homes, you know what I mean?
Right.
In IL, like I go to this one IL that actually has a nursing section, like a little nursing station. I don't know if many do, but the role of the nurse in the IL has been like a school nurse, right? And the nurses have kind of had, it depends on who you hire and what their capabilities are. The nurses in the IL feel like, well, if somebody has a medication issue, it's not our problem. Where the executive director and I felt strongly it was. Now, in assisted living, and it's similar to nursing homes, there's just different kind of engagement. Corporate says different things. I think, and I don't want to be crass or anything, I think you can make money from doing this sort of things, but part of it is like soft money. Like if you're doing something that prevents people from falling and prevents hospitalizations, you don't really see that right off the bat. It's like when a pharmaceutical company says, oh, you should use a pen rather than a vial because it decreases nursing time. That's soft money. You know what I mean? So you don't actually, it doesn't matter unless the price of the one is less than the other. So I think, to me, it's one of the many issues. Do you have the resources? Do you have the initiative? What are your finances? All this sort of different stuff.
Well, I think it sounds like you could take an entrepreneurial approach to it and think of some ways in which case,
I do, I agree. And we know, I know there are, if you guys like this topic, I think you could reach out to Kane and reach out to Meg or Joanne. We know medical directors who work at, big organizations, right, who do these sort of things. So, I mean, if you're interested, they'll get you a good speaker next time.
You're a great speaker, Dan. Dr. Dan, thank you so much.
Dr. Dan, you mentioned earlier in the presentation or the roundtable discussion that you had a joke. I wonder if we can finish this thing off with that joke that you mentioned.
Well,
even though I feel like you've had a few
which
zingers
I
throughout.
I forget already. What was the joke?
I don't know, but you mentioned that you had one and we could come back to it. So I was hoping to hear it. Maybe
my memory's bad. Sorry.
No worries.
Whatever
Great
it was,
job.
I'm sure it was really, really good. I remember saying that. I just don't remember what it was about. Sorry.
Well, no worries. We'll have you back. Great job, and thank you so much.
Thank you, everybody. I hope that helped.
Thank you, everyone,
awesome.
for joining. We appreciate
Thank you, everybody.
it. Bye-bye.